In our previous panel, we've touched on many technologies associated with surgery and intervention. We're going to do something a little bit different today. So in today's panel, might be a surprise to some degree to link some of those technologies back to pathology. Oftentimes when we think of pathology, we think of it in terms of diagnosis, or sometimes we may think of it in patients waiting for kind of a key result associated with cancer surgery and having quite a bit of anxiety on that. So today we're going to talk about pathology-enabled surgical guidance. And so when we talk about that, we're going to be looking at kind of two different areas, one dealing with augmented reality and one dealing with image fusion. So to chat about these things, I'm excited to introduce our two panelists. First, we have Dr. Mike Toff. He's an assistant professor of otolaryngology, head and neck surgery at Vanderbilt University Medical Center. Dr. Toff established the Head and Neck Surgical Oncology Research Fellowship, and he's currently director of that. He also won a recent NIH award, affiliated really with augmented reality and pathology within the context of head and neck surgery. So welcome, Mike. What I like about Mike's work, Dr. Toff's work, is that he is really breaking kind of conventional ways in which we integrate data to the surgical field. So it's really a step forward. Our second panelist today is Dr. John Houseman, who is a research assistant professor of biomedical engineering here at Vanderbilt. You also may have noticed, for those that have watched past videos, I didn't introduce myself as the director of the Master of Engineering in Surgery Intervention program. That is now John. John has an enormous amount of experience in the operating room. He spent time up at Memorial Sloan Kettering. He's a Vandy BME alum. So it's great to have him here kind of leading the program. He has infinitely more experience than I do, so he's the perfect person for the job. So with that, and with John's work in image fusion, what's really great about his work is it really represents kind of a link between biophysical understanding of things as well as kind of novel ways of assisting and guiding surgery, and all in the context, again, of some of this pathology work, which is pretty interesting. So full disclosure, I serve as a mentor to Dr. Toff. I'm one of his awards, and we also have grants together. And then with John, we're also on grants together. We work on the Welcome Leap program, so we do have some grants together and whatnot. So just put that out there. So welcome, guys. I really appreciate you both taking the time out of your schedules to chat with me and to kind of shoot the breeze over the next 30 minutes or so. So let's jump right in. So I'll start with you, Mike. Before we start discussing some of the kind of more details of the projects that you kind of work on, I thought getting kind of a broad understanding for the potential students out there, as well as the general audience, on the procedures you do in head and neck surgery. I think we all kind of know what surgery is, but you have particular challenges that you kind of face when you're doing that. So I think kind of getting a little bit of that, maybe even a little link to the engineering kind of side of it, perhaps, as you kind of go through, and then maybe you can give an example of some of the challenges that you're faced with on a daily basis.
Yeah. Mike, thanks so much for the opportunity to be on this panel today. I'm a head and neck cancer surgeon and reconstructive surgeon, and my clinical practice is the management of both benign and malignant tumors of the head and neck. What does that look like? That's a lot of oral cavity mouth cancer, oropharynx, back of throat cancer, and then voice box cancer, as well as advanced cutaneous malignancies that perhaps are just a little too large for in-office Mohs surgery by a dermatologist. I would say just a kind of a challenge for head and neck surgeons in particular is the lack of real estate, right? Our head and neck area has a lot of critical structures, neurovascular structures, the carotid artery, the jugular vein, many cranial nerves that serve extremely important functions for daily life. And that is pertinent for a cancer surgeon because a fundamental principle of cancer surgery is to remove a tumor en bloc with a rim of normal tissue. And if you don't have much of a real estate, I'm operating on the magnitude of millimeters on a daily basis. For some of the other engineers, I'll just point out that we do use robotic surgery in my field for oropharynx tumors. We do something called transoral robotic surgery, or TORS, and that is done through a single port robot transorally, and that is how tonsil and back of tongue, base of tongue cancer is managed surgically. But I'd say a challenge that is unique to head and neck cancer surgeons is that we're dealing with millimeters and an unbelievable amount of critical neurovascular structures.
Yeah. Tough place to work for the most. So just to flip over to John a little bit. So, you're an engineer, John, you're not a surgeon. And so, you have a whole different kind of skill set toolbox. And so I guess, from your perspective, when you observe surgery, like what do you see? You have different you've been in the different ORs and whatnot as well. But I guess, kind of what's your perception of those kinds of procedures, and what do you see? What are the things that, can you give us a walkthrough, a little bit of your experience and kind of how you understand the problem?
Yeah, definitely. First of all, thank you so much for kind of this opportunity to just chat and, talk about, what it's like to do work in this space. It's really wonderful to, come back to Vanderbilt and be, building within this sort of environment. To answer your question, though, the idea of like, what do we think about as engineers when we approach surgery, and really this interventional process in general? The way I think about it is sort of in engineering, we have what we call state models, right? Our understanding of, what is the condition of the patient? What are the parameters that are changing in the patient? And how do we manipulate these parameters to get an intended outcome? And really the diagnostic question that physicians are facing is similar in some degree, right? How do we assess the state of the patient? How do we modulate these parameters through treatment? So within this diagnostic question, treatment question, we're really working with a similar foundation, right? And as an engineer coming into surgery, then what we think about is really how do we start to encode these factors that physicians are looking at? How do we integrate new information from surgery, which might be multimodal in nature, right? It might be collected at different time points. And how do we build a sort of a comprehensive picture? We have other work happening across the board in the discipline in digital twin modeling, for example. How do we assemble these technologies together in a way that gives us a strong understanding of how the patient is going to sort of move through the treatment course, respond to treatment? How are we going to optimize this system in a way? And all that starts with what are we measuring from the patient? How do we model these factors of how the patient's going to respond? How do we assess really, once we've delivered treatment, has the appropriate outcome been achieved? How do we close this control loop, if we will, from an engineering perspective? So yeah, that's maybe a long-winded description, but I think the similarity between how engineers are perceiving a system and how physicians perceive a system, they're actually quite complementary.
Yeah, no, that's a great way to put it. And I think, as you can see, everybody in the audience, he's much better than I am for sure. But no, it's great. My next question for both of you was kind of what drew you to the work. But you guys are clearly, the passion's there. I can see it easily. So we'll move on to another question, kind of getting into the nitty gritty a little bit. But I think before we begin there, Mike, this goes to you. We're going to talk about pathology-enabled surgical guidance. Like that's where we're going right now. And I guess it would be useful from, for the audience, myself, to do a little bit about how pathology may be used kind of day to day right now in your work, and kind of, what is the kind of standard of care that you're currently kind of working with, and that'll set us up really nicely for where we're going in the research part of it.
Yeah. So during surgery, intraoperative pathology, we do a process called frozen section analysis, and frozen section analysis has been around for decades. It's been shown for most cancers to be very, very, very accurate, with accuracy greater than 95%. But basically, I remove a tumor, I send margins off that tumor or from the tumor bed, and that gets flash frozen. It gets affixed to a glass slide. They do some H&E staining, and then a pathologist is going to immediately microscopically interpret that result, and they're going to communicate those results back to me in the operating room via still just a telephone without any visual aid. Mm-hmm. That is a process that is being done. I'm upstairs on the third floor in the operating rooms with the pathology lab just outside, countless times a day. And it's how surgeons and pathologists communicate that critical information. And that may be diagnosis, or it may be margin based. Did the surgical oncologist remove the cancer completely?
Yeah, that's great. I mean, in some sense, while it connects it for the students, it also connects it for our patients that are in the population to understand kind of how, when they get that result and kind of there's a lot of process that goes through in order to get there. You're doing it intraoperatively, which I know some folks have to wait, post-operatively in order to get those results, but it's pretty nice for you to connect that to, really where the different steps along the way are, as well as kind of with respect to patients. And now let's kind of move into the research side of this thing, where you're using kind of an augmented reality approach to kind of improve surgical guidance in several. I know a little bit about it, so several different ways. And I guess first, can you give the audience a sense of augmented reality as what's that solution all about, and then maybe kind of how you're using it in this role, and give us a little sense of the power of it, really.
Yeah. So probably most in the audience know, but augmented reality superimposes a computer-generated image on a user's view of the real world. And for that reason, because it's not a virtual reality, there's been a lot of excitement and research into its use in surgery, because a surgeon can still see what they normally see. They just have added information. Where we started, actually back in 2020, Vanderbilt Diagnostic Pathology announced they were going to move off campus. They're going to move about 15 minutes away to a different area of Nashville. And I got really interested in finding a way to bring my head and neck cancer pathologist into the operating room with me. Mm-hmm. So it started with, let me wear a headset. We'll bring the pathologist into the operating room with me via, a Zoom or Teams meeting or whatever teleconference software you want to use. They can show me microscopic data via AR, and I can show them what the tumor bed and the specimen look like via AR, and we can have a more meaningful conversation, particularly because previously I used to have my pathologist, in-house with me. That's where we started. And then we got really excited about it. And we started, our team has a 3D scanning protocol where we 3D scan surgical specimens, mainly head and neck, but also breast and musculoskeletal bone and soft tissue sarcoma cases in real time, and create a 3D model of the resected cancer. We then use CAD software to annotate that model and show the sites of margins and sectioning. And now what we're really, really excited about is this end-to-end communication solution, which allows for a hologram 3D model of the resected cancer to be deformed to its initial state and then auto-registered back into the tumor bed. That way, if I need to take out further tissue, remember, dealing with on the order of millimeters here, of a close or positive margin, I have some AR guidance on exactly where I need to go.
Wow. Are you sure you're a surgeon? You sound like an engineer to me.
No, I just hang out with really smart engineers all the time, and computer scientists.
Very, very Star Trek-like, very cool. Yeah, so I think that's, so kind of flipping a little bit to John now. I mean, that's amazing, Mike. I think it's just a whole redefinition of kind of how we use pathology information. Very neat. John, you're kind of actually looking at different problems, so you're not quite in the same space. So I guess, can you give us a sense of the pathology problem that you're working on, maybe some of the standard of care associated with that, and the type of data that it's, I guess, bringing to bear in terms of the physicians? Then we'll kind of move on to kind of what your solution is.
Yeah, definitely. Right. So when we think about how we can advance surgical outcomes, right, there's the intra-procedural steps, right? Like how what Dr. Top is working on, how do we use augmented reality to tell us sort of where this pathology information is located back into the surgical cavity. That's really important, right? But another factor that's relevant to sort of surgical outcome is, are we selecting the right patients for the right procedures, right? Before we even enter the operating room, we need to have a sense of, is this the right procedure for this specific patient, right? And that's really the art of personalized therapeutic courses and treatment options. So the way that we're sort of incorporating pathology is, if we want to sort of establish who are the patients who are, have good, what we call neoadjuvant response. So before a patient comes into surgery, they've already started, perhaps, especially in cancer therapies, some sort of treatment course. And the question is, are they being prepared in an optimal way for this procedure, right? And if they have really good response, so their cancer is sort of shrinking the way that we hope it is, then can we perhaps downstage them to less aggressive therapy? We're also starting to see certain treatment courses establish what we call complete response, so no residual viable disease. And so the question is there a way that we can less invasively detect which patients can potentially be downstage, which patients might be able to even forego surgery? And that's a really critical factor that's sort of improving, in general, surgical outcomes. How can we reduce the severity of the treatment itself on the patient and improve really quality of life when they exit the sort of care continuum, right? So the way that we're incorporating pathology is essentially how can we correlate information from what we call whole mount pathology, which is taking an entire surgical specimen, and we have really cellular scale information of where malignancy exists within those pathology images, and how do we sort of align that, what we call registration, how do we sort of fuse that information with non-invasive imaging that we can take before the procedure, and how do we build machine learning models off of this to really get voxel scale accuracy and where residual disease exists within each patient.
That's really amazing. And I think it's something where we often think about specificity for drugs, and you've probably tumor fingerprinting has been out there, and we kind of understand that that precision aspect. But the idea of stratification for procedure and kind of understanding as you're going in and that staging, that's probably not quite as well by the general public is well known, but there's lots of room for improvement in there and to understand and really kind of make procedures as specific to the patient as possible. I think it's super fascinating work, and I think you did a great job of kind of helping us understand where image fusion kind of fits among that, which is really kind of taking this information and understanding what is it telling us for how should we treat this patient. So I think that's really great.
So Mike, and I'll just add, I think that is just an absolute perfect area to explore, because that is a serious clinical unmet need. We are increasingly, for many different solid malignancies, solid tumors, giving neoadjuvant therapy prior to surgery. Patients are getting chemo or immunotherapy prior to surgery in so many different types of cancer now. Particularly the immunotherapy, we're recognizing that it's really important to give immunotherapy while the tumor is still present, so that the immunotherapy and the immune response can recognize that antigen. So it's a shifting paradigm, but the time is right to investigate that. And I applaud John for going down that road.
No, that's great. Yeah. And I think, also aspects of surgery and the immune system really do play an important factor. There are aspects of other surgeries where, you become a little more immunocompromised with aggressive surgery. So some of the techniques we're working on in less invasive surgery actually help the immune system in the sense of kind of combating, the cancer, what's going on. So Mike, just sticking with you a little longer, let's talk about the things that go into your technology and what you've kind of experienced in the buildup of the technology. So, I'm sure in the aspects of design, which, the program that John is now directing has a very fundamental component about design and building prototypes. So those technologies you're working with are quite involved. I'm sure they're pretty complicated, and you've had to figure out essentially how to kind of work that in the operating room, and there's a lot of steps involved in. So I guess, can you walk us through maybe some design challenges that you faced when you're deploying the technology, and give us a sense of that environment for your application?
Yeah, I think it's really obviously important when you're starting to design these interventions to obviously start preclinical. So, I collaborate a lot with Dr. Zhiying Wu from computer science and the Vice, and, a lot of the coding and software builds are going on in her lab space with my kind of clinical input and needs. And then once we've got kind of a viable product, the next place we go is the cadaver lab for me, because I really and it's always fun to bring the master's and the PhD engineering students to the cadaver lab, and we go, yeah, we go pretty regularly. And I like that because it's a great model for me for surgery, because we're actually doing kind of not formalin fixed. We're doing fresh, previously frozen cadaver specimens. I find with the lab purchased a cautery machine, monopolar cautery machine, and I find that it's a great model and very, very realistic for soft tissue deformation, which is very, very important for our team. So we do a lot of work in the cadaver lab as well, just testing before we go to the actual operating room, because it probably doesn't need to be said, but I'll say it. Surgeons, we're an impatient bunch. And particularly during surgery, we just want to go. There's so much set up. And I like to make sure that our kind of protocols are very tight, and we've made some of those errors, and we've kind of increased our efficiency in the lab. So there's kind of a lot that goes on before we actually, do something to actual patients under institutional review board approval, of course.
Sure. Yeah. The sobering realities for our engineers as they come into this field. There's lots of things you deal with before you actually get to the patient.
Yeah.
So John, I mean, you're the design instructor. You're actually seeing a lot of different aspects of design going into different technologies with the students. You're working in a different framework yourself for the kind of research work that you do. So I guess maybe you can give us a sense of we all can do things on a workbench, and things work great there sometimes, but kind of realizing from the OR or the interventional suite, oftentimes we have to re-realize in order to kind of accomplish those. I guess so some of your experience there, I guess what your thoughts are on that process.
Yeah, I would mention, so sort of to echo one thing that Dr. Toff mentioned, this question of deformation, right? How do we transform information between one state and another state, right? Tissues are soft, they move around a lot. That's one very important aspect of this idea of transforming information. But also there's sort of this question of intermodality transformation, right? That when you're measuring from, say, pathology, you're measuring a fundamentally different quantity than if you're, say, taking a camera image of the surgical scene, right? And the question is, how do we sort of how do we marry these modalities and have information transfer from one way of perceiving the patient state, going back to that idea, and applying it into this other view of the patient state, right? So I would say that's one of the major challenges that when it comes to sort of contextualizing information across the treatment course, that we as engineers we're the ones who can build these systems that are really building ways to visually represent and allow surgeons to more really comprehensively cognize the way that information is being sort of integrated or sort of within the treatment course.
So along that same line, start with you, John. So one of the features of the master's program is clinical immersion. We're going to skip ahead a couple of our questions that we kind of planned, but with clinical immersion, you're kind of getting into that right now. And I guess and I'm going to go back to Mike on this. As you think about pathology-enabled, surgical guidance, how important is it for the students to get that exposure? And what does that need to be? Like, why is Vanderbilt unique in that?
Yeah, I think it's one of the most important things an engineer can do to really build effective tools for the clinic, that you really fundamentally have to understand the environment into which the tools you're building are going to be deployed, how they're going to be used, how you need to sort of both evaluate as well as drive usability, right? If you're, as Dr. Choff mentioned, surgeons, some surgeons are exceptionally patient, right? Very few are, but the majority of surgeons typically skew lower on patients because they realize the importance of, say, operating time. There are exceptional costs to it. There are implications for the patient themselves, like the longer the procedure goes on, right? So there are so many drivers that exist within the clinic that until you really experience what it's like to operate within that environment, and you've you spend time with physicians and you really talk to them and understand what they need out of a solution, there are so many factors that you'll miss that really are essential to this question of adoption. And so really it takes a level of immersion. And this also kind of mirrors the clinical training paradigm, where residency is really important if you're going to be a effective physician, to understand the entire continuity of patient care. And that's one of the reasons why residents spend so much time in the hospital during training. And we as engineers, we have like the light version of that. We don't spend, we're not stuck in the hospital 90 hours, right? 90 hours per week with it. Anyway,
Mike, you doing 90 hours there? It's good.
Oh,
what do you
not
think
anymore.
For clinical immersion? I mean, you have your students doing both preclinical, cadaver, and probably in the clinic as well. Some quick thoughts on that yourself, I guess, in terms of its importance.
Just emphasize, to John's point, I think it's also really important for clinicians to, it's a two-way street. I think, it's helpful for me and it helps me kind of grow my patients as a collaborator to see how challenging some of, for what I do, some of the coding is for the augmented reality software, and that it's not as easy as, oh, I want this, I want that, build it for me. And there are, hardware and software limitations to augmented reality guided to surgery. But I just emphasize, I think it's, hanging out with pathologists, going back to, path-enabled guidance, hanging out with pathologists and seeing how they process my specimens and what, how we go from, I just took out the cancer to, the pathology, what's on the glass slide has fundamentally transformed how I take out the specimens. Just watching, the pathologist process them. So I encourage anyone who's listening to this to spend a day in someone else's shoes if you have interest in that topic.
Yeah, I think that's fascinating. You really, by interacting in this space, right, you're changing kind of the way you think about things, the way you practice things. I always call these kinds of experiences like a real domain experience, as opposed to real world application. Real world application, implies some refinement that's already going in a given direction. I think these conversations, this dialogue between engineers and surgeons are so critical. And I think seeing both workflows and kind of understanding, it's so necessary to create the technologies of the future, that type of thing. We're getting close to running out of time, so I'm going to leave one last question. I had a lot more questions for you. Sorry we didn't get to them. It was fascinating the whole time. I guess as far as like tips going forward, we have students and folks out there kind of thinking about the domain. I guess, do you have any kind of advice to them? We'll go through John first, Mike second, but any advice and maybe some areas that are important for them to kind of think about as they kind of perhaps move into this area?
Yeah, I would say for aspiring engineers who want to get in the area is really to approach things from a needs-based, a clinical needs focus, as opposed to a capability or technical tools-based focus. If you really want to do impactful work, it's a combination of really it's about seeking alignment, right? So what is it that you are good at, and what is it that the world needs, right? Yeah. And really finding that intersection point is really critical. And how you kind of go about doing that is really listening to what is it that people need, how much of that is sort of within your skill set, what additional skills might you need to learn and gain to become effective in that area and to actually be able to help these real world problems. So that would be my suggestion. Go out and explore really and talk to physicians, talk about what is it that you can potentially help them with, right?
There's your first lessons in design, folks out there, if you want to know. Mike, real quick, do you have anything to add to that?
Emphasize that you should always start with a clinical unmet need, because if there isn't a problem there to begin with, then why work on it?
More creative, right?
And then, for me in particular, on the clinician side, I think, and it applies to engineers as well, but have fun. Like, do research that you are excited about, that with people that you interact well with, because it should be fun. Science should be fun.
That's great. No, good advice there. Very good advice. So, folks, that's about all we have time for. We're a little over. Sorry about that. I'd like to thank both Mike and John for taking the time to sit and chat with us. I think we learned a lot today. Definitely a different topic than we've ever covered before, and I think there's a lot of impact. I love the specificity. It's all great work. Very interesting. Love to have some demos on here, but we don't have time for that, unfortunately. So I know how busy you both are, so I greatly appreciate kind of the time you took to kind of talk about your cutting edge work, as well as kind of giving us a little bit of perspective on kind of engineers and surgeons and working together. So lastly, this closes out the panels for the year. So be sure to look for our next installments in the fall. It'll be fun. I hope it's all new topics. So I hope you enjoyed it. And I'll give you my signature disclaimer, which is I'm not an expert webcaster. I am just an engineer, researcher trying to learn, similar to John and Mike, really. So if I've fumbled and I bumbled it, I always try to tell my kids I'll do better next time. So take care, folks, and thanks for watching.
Yeah, thank you so much for having us as well.
It's all good. Thanks.
All right, take care.